let's move on and now turn our attention to isocitrate dehydrogenase, the IDH inhibitors. And Dan, you've had a leading role in the development of those drugs.
Yeah, you know, I mean, this has been a fascinating story. I think, again, at this point, most people are pretty aware of what's happened in the last several years. IDH1, you know, was first identified in the first cancer genome, full genome sequencing, and was not on the radar of anyone in the AML world. And now we know that it's a recurrent mutation, and it and its isoform IDH2 make up upwards of 20% of all of AML. And very quickly, the field has developed inhibitors for these therapies, and you know, these inhibitors have very quickly been approved by the FDA for general use. So I think, you know, we all have quite a bit of familiarity with these, and I think we're pretty excited. I think, you know, at this meeting, some of the new data that we're hearing about are perhaps combining them with hypomethylator backbones and moving them into the upfront setting. And I think, like, you know, Mark was commenting on his enthusiasm for that strategy in the you know, with very specific FLT3 inhibitors. I think the same principle may apply with IDH, and I think that's, you know, where a lot of colleagues and people at this table are moving toward.
I think some of the challenges, like, because the patients with IDH mutation do well with the other combination as well. So the most common question you get asked now, you have a patient with IDH mutation up front, not fit for intensive chemotherapy. Are you going to do azacitidine venetoclax, or are you going to do an IDH inhibitors? And I don't think we have the answer. I think both are good options. One of the areas that I find helpful, because I also do a lot of MDS, is patients in MDS after HMA failure, when they progress to AML, they don't have options. That HMA venetoclax combination is not as viable for them, and many of them are not candidate for intensive chemotherapy. So if they have the mutation, I think single agent in that setting is reasonable, because they don't necessarily even do well with intensive chemotherapy.
And it can be dramatically effective.
Right.
Yeah, and actually, didn't Courtney present some data about IDH mutations in those secondary AMLs?
So we have a study. It's a multi-center study through the MDS cooperative group, looking at exactly what Rami is saying, patients with MDS who had AZA and either at MDS relapse had IDH or transformation to AML had IDH. And if I recall, the response rate was similar to what you see with IDH in relapse AML, about 35–40%, which is good, because those people, if they've had at least 4 to 6 HMAs, a good trial, don't have much durability with HMA ven. They may have a short response, but it's very short-lived. But, you know, getting to that point, I think the same, for IDH, I don't feel bad. If I started HMA ven and I find a new AML has IDH, is not fit, I'm like, that's okay. The data is so neck and neck. For FLT3, there was data here actually showing that with and this is some data that, you know, we've been analyzing internally, is that with HMA ven, the response rates are good, about 60–65%, but the survival is lower than the general. It's about 11–12 months. This was shown by the AbbVie, combining everything. They relapse with the FLT3, and that's also been shown in the lab. So I think this is where doublets, you know, adding maybe a FLT3 inhibitor, it may help. And there was some data with a combination of venetoclax, gilteritinib, showing very high responses in relapse. So more than IDH, I think FLT3, we may feel that HMA ven is not optimal at this time. Yeah.
So Courtney actually at this meeting presented data for enasidenib in IDH2 mutated patients in that randomized phase 2 study of enasidenib AZA versus AZA alone. And of course, compared to AZA alone, there was much higher response rates. And it does become an option for your previously untreated patient. And before that, she presented data for ivosidenib with last year, ivosidenib with azacitidine. Overall response rate of 80%, 67% CR/CRi rate, 80% of patients are alive at 1 year.
And I know you don't like MRD, but in fact, the molecular response went down. And in that New England Journal article of ivosidenib, the molecular response was nicely correlated with survival, although it was a small data subset.
It was. Okay, so just devil's advocate. Yeah. So in the paper by Stein, where they looked at a larger subset of enasidenib, I was impressed that when they looked at their CR patients with enasidenib, MRD status made no difference in long-term survival. And I thought that was...
No, but I agree. I actually think IDH1 and 2 are different. Yeah. I really do.
But you know, actually in
I think IDH1 is a cleaner mutation.
But in the New England paper, the visual impression is very good, but the
Oh, I know, the
p-value is
spike
not
values are-
significant. Yeah. So it's good to
Yes,
see it.
yes,
We're
yes,
all
yes.
happy, but we don't know.
But let me talk about one thing that I don't think Courtney presented it for the enasidenib combination, but she did present it for the ivosidenib combination. And one thing that impressed me in the few times I've used it is the blood counts don't go down. They actually go up immediately. And that might be the one distinguishing feature between the IDH inhibitor with an HMA versus venetoclax with an HMA. And of course, we don't have any comparative data. At the end of the day, you know what I do? I try to make it easier for the people who do prior authorizations. So Ven is approved up front, and although ivosidenib is approved in the first-line setting, it's also approved in relapse refractory. So it just makes it easier for my staff to sequence it that way.
The other sort of logistics issue that's a little bit easier is just with respect to do you wait with venetoclax, do you have to wait for any molecular mutations to come back, or can you feel comfortable moving forward with that as a
Yeah, you don't have to wait for the IDH, it's true.
Yeah,
But on the other
IDH
hand, if you've got an indolent older patient, an HMA Ven will occasionally be a rough ride, and yet you want something to give you a little more oomph than just the single agent. So I think the combination has a lot of appeal.